اوكي، على بركة الله نبدو الناينث webinar of our society. الكل يسمع؟
ايه نسمع
أي تمام.
دكتور خالد.
Okay. Our speaker today is Dr. Ibrahim Abdul Momen, and it is a pleasure for me to present one of my previous juniors who started his career in the rheumatology department of Tripoli Medical Center. Dr. Ibrahim is in between consultant physician and rheumatologist. He is Arab board certified. He completed 3-year rheumatology fellowship program at the Hamad Medical Corporation. He is certified clinical densitometrist. Is also certified level 2 Euler musculoskeletal ultrasound. He has many interested areas, including crystal-induced arthritis, osteoporosis, spondyloarthropathies, and last but not least, he is member of Qatar Rheumatology Association, member of Qatar Osteoporosis Association and ISCD. He will talk today about axial spondyloarthritis and focus on the imaging and assessment tools. Dr. Ibrahim, the microphone is yours.
السلام عليكم. بسم الله الرحمن الرحيم. السلام عليكم. It's also my pleasure, Dr. Khalid. Actually, it is a privilege and pleasure that Dr. Khalid introduced me. Thank you so much for the kind introduction. And this is, I think, the number 9 webinar in the Libyan Rheumatology Libyan Society. As Dr. Khalid, the topic today is axial spondyloarthropathy and diagnosis and assessment tools. Actually, the topic it was only assessment tools, but I add the diagnosis. I found that is also important point that maybe go through. It is very clinical. Helpful in the daily clinical يعني. we'll start إن شاء الله. So this is my agenda. I will discuss 2 parts. The part 1 is diagnosis of axial SPA, and it will go through the sacroiliac joint X-ray. Will mention about the New York modified criteria. Then I will discuss maybe in little detail about the MRI definition of active sacroiliitis and other lesions. Then finally, there is some new definition regarding the how to define the sacroiliitis related to axial SPA. Then the part 2 will be the clinical assessment outcome measurement of axial SPA. We will go throughout the 2 clinical assessment tool, which is the assess the function and the assess the disease activity. So as you can see from the agenda, I will concentrate only the axial SPA. It will be mainly in sacroiliac joint. So this is the part 1. As you know, the diagnosis of axial SPA is mainly 2 parts. It is inflammatory back pain, and you need to have sacroiliitis on imaging, or in other the pathway is the HLA-B27 plus 2 other features with SPA features, as you can see here. And for the sacroiliitis imaging, you will see here either, I don't know, can you see my pointer?
Yes, yes, we can.
Yes, yeah. So either you can define the sacroiliitis by X-ray or by MRI. So the sacroiliitis, or the diagnosis of axial SpA, it's mainly inflammatory back pain and imaging. If you see the inflammatory back pain through the different criteria, you will see there is no perfect one. Even if you see the inflammatory back pain with the last one in the assess expert criteria, still there is percentage that maybe they have axial SpA without classical inflammatory back pain. And in the clinical practice, I'm sure that most of you dealing with patient history of inflammatory back pain sometimes is so difficult. And the history sometimes is giving the mixed between the mechanical, inflammatory, and sometimes if you giving the history mechanical pain and they find out at the end it is axial SpA, and vice versa. Sometimes they will give you classical inflammatory back pain, and if we work up on the end of the workup, we'll find that this patient doesn't have axial SpA. So the inflammatory back pain, something is still subjective and less specific and even less sensitive. Then if you have considered after the history, you will take the lab and imaging. Lab is mainly HLA-B27 and CRP and ESR. But when you know that in the CRP ESR is both of them is not specific, is even not sensitive. It's quite patient, or it is uncommon to find a patient with axial SpA and they have normal CRP, normal ESR. HLA-B27 is very good, it is a predictor and very risk factor for developing axial SpA, but it is negative HLA-B27 doesn't exclude, and even positive HLA-B27 doesn't confirming the diagnosis of axial SpA. So the left thing is the imaging, which include X-ray and the MRI. So if they summarize the previous slide, the hallmark of sacroiliitis is imaging in sacroiliitis and inflammatory back pain. And of course, importance of early diagnosis and early treatment. And diagnosis strongly rely on the imaging. So we will start with the X-ray. So all of you know that the New York criteria, it released in 1966, long time ago, and they defined the sacroiliitis at the grading. So from grade 0 till the grade 4. Grade 0, grade 1, almost the same. So normal and suspicion change. Grade 2, it is minimal abnormality of the sacroiliac joint, but without alternation of the joint space. So it will have minimal change, but with normal joint space. And there is no ankylosing, no widening of the joint space. While the grade 3, it is grade 2 plus, you will see widening, what we saw, Z widening of the sacroiliac joint and partial ankylosing. Grade 4, which is easy to pick up, it is severely abnormal and totally ankylosing. So grade 3, grade 4 in clinical practice is too easy to pick up, while grade 2 sometimes plus minus. Even if you have expert for X-ray, you will see the different opinions. So you will see this is maybe grade 2, grade 1, and vice versa. And remember, the New York criteria definition, you need to have bilateral grade 2 or unilateral grade 3 or grade 4. We'll see. So you can see now X-ray. maybe we'll discuss this better. So it is the correct answer, or the not the correct answer, the most likely the option correctly is the grade 2 bilateral. And you know why? This is the joint, you can see the joint. I can argue maybe it's grade 2 here because of some ankylosing this part, but the joint is still okay. Joint space, I mean, still okay. There is some sclerosis. Joint is abnormal, bilateral. So it is grade 2 bilateral. And if the grade 2 bilateral, according to New York criteria, it will fit for they will fit for New York criteria, modified New York criteria definition of sacroiliitis in the X-ray. However, if you rely only the X-ray, so it is also that meaning you need sometimes 7-10 years to see these changes, the minimal changes, grade 2 or grade 3. And sometimes take up to 10 years, as I mentioned. And this is, we called radiographic stage. Radiographic stage, that means if you have patient with X-ray fulfill the criteria of New York criteria, this is what we name it as radiographic SPA. But before that, we know that if you do MRI for patient have axial SPA, but there is no X-ray changes in according to the modified New York criteria, still you can diagnose sacroiliitis, and this stage we name it like non-radiographic stage. So non-radiographic stage and radiographic stage is just historical story, because in the past there is no MRI, and this is the definition. It's like radiographic axial SPA. Now that we have the MRI and we can define the patient even before the X-ray change, so we call non-radiographic stage. And the problem with X-ray, because the X-ray, they cannot see any kind of inflammation that we have seen in other modality of the imaging. So X-ray, they cannot see pulmonary edema. X-ray, they cannot see the synovitis or capsulitis. X-ray is good for erosion, but also they cannot see the fat lesion, which is also another structure damage features. X-ray also good for sclerosis and new pore formation, but is less sensitive compared with the CT scan. Ultrasound, which is the other imaging modality, it is very limited using in the axial SPA, especially in the sacroiliac joint, because it is the deep structure and difficult to assess. But sometimes if we, with good experience and good utility of ultrasound, maybe you can see synovitis or capsulitis plus minus, but it is maybe you can see synovitis. But otherwise, you cannot see any bone edema, you cannot see the erosion, you cannot see fat lesion, you cannot see the new pore formation. However, MRI, they can see everything. They can see inflammation, which is include pulmonary edema, synovitis, capsulitis. Also, you can see the structural damage, which include the erosion, fat lesion, and sclerosis. CT scan, of course, it is very good modality to see erosion and the new pore formation. Actually, CT scan is the gold standard for erosion and sclerosis, even if you compare with the MRI. But otherwise, we cannot see any inflammation sign in the CT scan. So that's why the next step after the X-ray, you need something more sensitive to see early sacroiliitis, which is MRI. So before MRI, I just do reviewing some basic anatomy regarding the sacroiliac joint. The sacroiliac joint is compared from the sacrum and ilium. And remember this, the sacroiliac joint, it is C-shaped initially in the anteriorly. And this is the yellow part is representative the synovium or real articular joint. While the pink part, the other color, it is represented as interosseous ligament. So it is fibrous ligament joint, it's not real joint. So that's why we need to see this part, MRI, and we need to rely on that part to interpret correctly regarding the MRI. And in the MRI, this is the second question. In MRI, we have many planes. So we have one of the plane is what we call named coronal plane. So one of the picture is the coronal plane. It is P, A, or B, or C. Again, I would refer you for the menti.com. So the A is the coronal plane, but in MRI, if you're dealing with sacroiliac joint, we need some technique, what we call semi-coronal. Is not coronal. If you do coronal like this, so you will miss the most of the joint, and we will give you something not a good view of the sacroiliac joint. That's why we need to do it MRI like this, what we named semi-coronal orientation. So when you do this, then you will see this image. And this is anterior part, and this is the posterior part. In the anterior part, in the middle of the sacroiliac joint, this is the image. And this is the most important part when you're dealing with MRI. This is the typical part that you see the lesion of the sacroiliitis axial spot. And of course, we have different modality of MRI. So we have modality where you can see the fat as hypertense, and there is another modality you can see the water is hypertense. I will not discuss all the modality, but I will just give you or just concentrate two different sequences. T1 weighted, which is fat sensitive. In T1, you will see everything is black, hypotenuse, except the fat, which include subcutaneous fat tissue, and would include post-inflammatory region, what we call fat metaplasia. We'll see later the sample of image. And the other modality or other sequence, which we named STAIR, we will see everything is black or hypotenuse except water. So that's we named water sensitive image. So we will see any type of water in that image, it will be high signal. Fat will be black. Again, so the T1, fat is white and the water is black. STAIR is completely opposite. Fat is black and the water is white. And that's why T1 is good modality to see the structural damage, while STAIR will see the inflammation sign. So this is the question 3. Which one is T1 and which one is the STAIR? So there's two options. 1, A is T1 and B is STAIR. 2, B is T1 and the A is STAIR. Seems to be no one is so active in that Menti.com. I mean, not no one, yani most of you. Okay, so let's see which one is T1 and which one is STAIR. So I mentioned that in T1, the fat is high signal, which gave you white in the image. So this is the fat, subcutaneous fat. It's white. This is white because it's fat metaplasia. Here in the disc, there is which contact of water, and see here is black. And you can see here blood vessel, which also indicate water. You can see here is black. While in the STAIR, everything is opposite. So the water here is white, the blood vessel is white, and the fat is black. You see, the fat is here is white, the fat here is black. Fat here is white, the fat here is black. So when you see the definition of active sacroiliitis according to the ASAS definition, you need to have subchondral periartical pulmonary edema in typical anatomical area. And you need to have 2 or more than 2 pulmonary edema lesion in one slice, or more than 1 pulmonary edema lesion in 2 consecutive slices. And maybe you consider other lesion as supportive is not mandatory. So this is 3 consecutive slides for one patient. And you can see this is stair. How you know stair? This is white here in the disc. This is black subcutaneous. So this is a stair. And this is the sacroiliac joint. This is sacroiliac joint. And you can see here hypersignal subchondral sacroiliac joint in one slide, second slide, and third slide. So according to the ASAS definition, it is fulfilled active sacroiliitis for SPA. But be careful, because pulmonary edema is not exclusively seen in the axial SPA. So there is study show that up to 25% of patients with low back pain and even healthy individual, they can have non-specific pulmonary edema on sacroiliac joint MRI. That's why you need something which we call other point in the MRI. They support always, it's not mandatory, but they support the sacroiliitis axial SPA. So for inflammation, in addition to pulmonary edema with that I mentioned, you can see synovitis. This is the synovitis here. So this is sacroiliac joint, and this is the joint, and this is the hypersignal white lesion here, which represented synovitis. And also you can see capsulitis, which here, this is hypersignal white in the capsule of the joint here. So it's named capsulitis. So we have 3-point inflammation in the stair, and you have erosion. You can see here erosion, 1 erosion here, 2 erosion here, 3 erosion here. And also you can see widening of the joint here, with the represented erosion makes the sacroiliac joint is white. And also you can see sclerosis, which is black here around the sacroiliac joint. And also you can see fat metaplegia, which is this represented here. It's a huge fat metaplegia here and here. So this is 3-point represented the structural damage, and we have 3-point represented the inflammation. So sometimes you have patient with axial SPA, typical inflammatory back pain, HLA-B27, and they have other features supported axial SPA. And MRI doesn't fit for ASAS expert criteria. As you can see here, this is again stair. Why stair? This is white blood. This is, you can see the white signal in the blood vessel. You can see white signal in the disc here, and the black fat here. The subcutaneous fat is black. Here we cannot see significant edema around the sacroiliac joint. So in the stair image, you cannot see definite indicated that patient has sacroiliitis. But if you see the same level in the T1 image, you can see significant erosion, and you can see fat metaplegia at the joint itself. So you can see here, one here and one here. And you can see another erosion here. It's a small erosion here, but there's significant erosion here. So here, fat at the erosion area, like this, it was exclusively recorded in axial SPA patients. And there is very interesting study done in, published in 2018, where they compare typical axial SPA taken from space cohort, where the diagnosis axial SPA, positive ASAS criteria for sacroiliac joint, comparing with the patient who has completely healthy or runny athletic patient or postpartum lady. And they do MRI for this 3 group, comparing with MRI with the space cohort, is taken from the space cohort and reviewed by 3 different musculoskeletal radiologists. And they found 23% from healthy patient is fit criteria for SS, spare criteria for sacroiliitis. 13 patient from 24 athletic healthy individual. Sorry, this is healthy individual, and 57% from postpartum women. So all this group has significant, or they have edema, which it fulfills the criteria of SS, while they have no axial SPA features. In that study, they do something more to differentiate between these completely healthy and they have edema compared with the other, with this typical axial SPA. And that study, they give another point for the edema. If they have deep edema, more than 1 centimeter, it found only in the mainly or only in the real axial SPA, in some percentage in the postpartum women. In that study, they conclude deep extensive pulmonary edema lesion are almost exclusively found in axial SPA patients. Another nice study I found it in the MRI. We thought that MRI is less sensitive for erosion comparing with CT scan. But in this study, they compare the X-ray and the MRI with gold standard CT scan, and that study conclude T1 MRI was superior to radiograph in detection of structural lesion in the sacroiliac joint in patient with axial SPA. So in summary, in that study, in the MRI, they can give you everything, including erosion. Of course, we cannot depend on MRI, we cannot depend on the lab, but if you take whole thing all together, then you can find the real axial SPA patient. And this is the part 1. Now it will go for the part 2, which is clinical assessment and outcome measurements. I will start with the first tools, which we call PAT ankylosing spondylitis functional index, which we named PASFI. In this PASFI, there is question where they can ask the patient how to do some function, like how to put the socks, how to bending, how to do the things over the hand, over the head. And this is the question from 0 to 10. And we have to take the mean of this question, and we will find the score between 0 to 10. And if you have high score, indicate high degree of the function limitation. So this will give you idea how your patient is limited because of the study, because of the disease, sorry. The second thing, then there's some measurement you have to do, especially in the first visit, which include modified Schober test. Of course, all you know, this is how do you do the modified Schober test. The second one is lateral spinal flexion. The third one, occipital two-wall measurement. The other one is cervical rotation. And finally is chest expansion. And these all include is PASME. So we have PASFI and PASME. PASFI, it is assess the function. PASME, it assess the spinal mobility. But remember, in the PASME, it includes all measurements that I mentioned except the chest expansion. So this is spinal mobility. But these two tools, it only assess the damage. That means it is, of course, you need to see this, how your patient, the disease is affecting your patient. So we need some tools to start with the patient, especially in the first visit. But of course, definitely it makes no sense to doing every visit. This is damage. So damage, that means something happened. And the clinic, we need something to prevent in the future. So both of them, PASME, PASFI, it indicate damage. It's not indicate the activity. So there is another score or another tools to assist the activity, which include PASDAI and ASDAS. So PASDAI, it is a questionnaire mainly depend in the patient. So how the pain affecting the neck and the spine, how the pain affecting the peripheral rather than the spine, and how the morning stiffness, then how the disease overall. Then you have the calculation. They will give you how much the PASDAI for this patient. Sorry for this for PASDAI, it is include neck and enthesitis, and for morning stiffness it include two questions: how much the degree the morning stiffness and how long the morning stiffness that you have the patient. But in ASDAS, it is like a summary of PASDAI, and addition of that, it is include CRB. So they have a question from the patient, outcome from the patient, and you will add C-reactive protein or ESR. And there is a calculation, they will give you the score of all this question. And don't worry about the score. There's many apps. It's easy to calculate whatever. So you have ASDAS or PASDAI. Then because this is the very complex equation to see the score. So I just give you two apps. One app is Roma Helper, then include everything, not every for the ankylosing spondylitis or axial SpA. It includes even for the rheumatoid, for SLE, and this is, by the way, very good app. It is very helpful, and I use it for my daily practice. The other one is created by ASAS itself. It will concentrate only in the ASDAS, PASDAI, and other features, and it's also very helpful. And finally, for the EULAR update recommendation treatment for SpA, they recommend ASDAS over the PASDAI because the ASDAS it's the combination of the patient outcome and CRB, while PASDAI is only patient outcome. There is no CRB or ESR, and also it had ASDAS, it studies and it has longitudinal relation with the radiographic spine progression. And also they have a validated cutoff remission and low disease activity. This is the cutoff of the disease remission. It will less than 1.3, and you have low disease activity range, and you have high disease activity, and you have very high disease activity. And how we use it in the clinical practice. So if you have a patient and you start the management, and every visit you score the ASDAS, if you see the improvement more than or equal 1.1, this is clinically important improvement. If you see improvement more than 2, this is the major improvement. And if you see the less than the improvement in less than 1.1, it is clinically important worsening. And as you know, the updated ASAS EULAR recommendation management in the phase 1, after the trial with the NSAIDs, and the patient is not responding, so you will go for phase 2. In the phase 2, here you can see the ASDAS, how you will use it. If the ASDAS improvement more than 1.1, so you will continue. If not, at the 12th week, you need to make some change. And why 12 week mentioned in the recommendation? Because there is a study in 2017 showed that if you have patient in very high disease activity at 12 week, very unlikely to get improvement later on at the 1 or at 1.5 years. And this is my reference. And thank you. I'm ready for your question.